Let's Fight HIV Texas Patient Education Program presentation. In 2021, there were 36,136 new cases of HIV diagnosed in the United States. Although it's a 7% decrease in the annual number of new cases since 2017, as of 2021, there were approximately 1.2 million people with reported cases of HIV. However, it's estimated that only 87% of individuals are aware of their status. Furthermore, about 13% of people need HIV testing but are unaware. In this slide, we can see the HIV infections by the US regions as of 2021. And I would like you to note down here in the bottom, the South represents 52% of all HIV infections. So the South has the highest number of people living with HIV with a rate of 387.9 per 100,000. Male-to-male sexual contact accounts for 67% of the total new HIV diagnosis in 2021. It's important to know that HIV does not discriminate, and it impacts individuals across the nation, especially among minority groups. African Americans account for 40% of all new HIV diagnoses, and Hispanic and Latino individuals follow by accounting for 29% of all new diagnoses. However, African American, gay, and bisexual males are the most affected subpopulation. In the state of Texas, there were 100,700 people living with HIV in 2021. And there were 4,363 new cases reported in that same year. What's more concerning is that the current rate of HIV in Texas is 415 per 100,000, which is higher than the rate across the United States. Furthermore, 79.2% of males account for the majority of HIV cases. Meanwhile, 36% of Hispanic and Latinx and 35.5% of African Americans account for the majority of cases in the state of Texas. When it comes to new HIV diagnosis, there were a total of 4,363, with a rate of new HIV cases of 18 per 100,000. Males account for 82.8% of new HIV cases diagnosed, and minority groups are still the most affected, with Hispanic and Latinx accounting for 43.1% and African Americans accounting for 33.6%. Here we can see the distribution by county, and we can see that the southeast portion of the state is the most affected. So what are the challenges? Well, currently, 20.9% of new HIV diagnoses are diagnosed late, which means that the receiving of medical care is delayed. As of 2021, only 75% of individuals living with HIV were receiving medical treatment. Although the new rate of new HIV diagnosis has decreased and the number of cases is steady, currently individuals aged 25 to 34 account for 38.4%. And the majority of the issue lies in people not getting tested and being unaware of their status, which impacts when and how they receive life-saving treatment. There's one program in the state of Texas that focuses on providing HIV services for communities statewide. the Department of State Health Services, DSHS, HIV STD program. The program works to report, prevent, and control HIV, AIDS, and STDs while addressing complications and costs. With the help of community-based agencies, this program educates communities while providing education, prevention, screening, medical, and social services. Their mission is to prevent, treat, and control the spread of communicable diseases in an effort to protect the public health of Texas citizens. This program also incorporates the Texas HIV Medication Program, THMP, which is a part of the AIDS Drug Assistance Program, ADAP. The medication program focuses on providing medications as part of HIV treatment for low-income individuals in the state of Texas. The HIV STD program provides paper and electronic education materials that include pamphlets, posters, videos, as well as fact sheets. They address the barriers to accessing HIV care by providing free testing resources, and case managers are available for those who are part of the low-income or uninsured demographic. And they help provide individuals with HIV diagnosis with new medical providers in order to receive routine testing and receive preventative medication as well as treatment for those living with HIV. However, there is a limiting factor, is that the current need for more outreach to be done to provide in order to provide services through Texas communities. And this is where the Let's Fight HIV Texas program comes in. The purpose of this program is to provide health education about HIV prevention, testing, and treatment in order to reduce the number of new cases diagnosed and increase HIV awareness among people to know their status and seek treatment. The target audience for the program is males aged 25 to 34, with a focus on racial and ethnic minority groups. Within this age group, we will be focusing on the Hispanic and Latinx individuals who have the highest rate of new infections, as they account for 44.37%, as well as Black individuals who account for 32.11%, which is higher than their white counterparts, who only account for 17.66% of new infections. By partnering with local health departments across the state, we can focus on delivering a tailored, individualized HIV education, screening, and treatments resources to the community's need. By taking advantage of the federal grants for HIV community programs, the program will encourage individuals to participate in routine HIV screenings and know their status, while also providing treatment and prevention resources and educating participants on the importance of routine screenings, preventions, and treatment to reduce the stigma and the rate of HIV transmission in the state of Texas. The program will be successful by emphasizing the empowerment and self-responsibility, by positioning the campaign as an opportunity for men to take charge of their health and their future, as it appeals to their desire for autonomy and control. It aims to motivate men to make informed decisions and engage in preventative behaviors and seek the appropriate support. So, phase one, the social assessment. It's going to use a combination of quantitative and qualitative research methods for social assessment. We're going to conduct surveys and interviews with individuals from the target population, as well as analyze the existing data on reports on HIV prevalence and healthcare access in Texas. We will collaborate with local health departments and community organizations to gather insights from the key stakeholders. In terms of quality of life indicators, we will assess factors such as access to healthcare, HIV knowledge and awareness, stigma and discrimination, the social support available, and the mental health. These indicators will help us understand the social determinants of health that influence HIV prevention, testing, and treatment behaviors among our target population of minority groups, of men 25 to 34 in the minority groups. Our epidemiological assessment. To assess the current behaviors, environments, and health of the population, we will use primary data collection techniques, including surveys, interviews, and focus groups. And we will gather information on the HIV risk behaviors, knowledge, and attitudes through this primary data collection techniques. We will use secondary data resources, including the current epidemiological data available in HIV surveillance reports from the CDC, to understand the prevalence and distribution of HIV in the target population through secondary data analysis. The educational and ecological assessment. We're going to assess the predisposing, reinforcing, and enabling factors impacting the target population's HIV-related behaviors. The predisposing factors will assess the individual's characteristics, beliefs, and knowledge through surveys and interviews. The reinforcing factors will assess the social support, the social norms, and the cultural factors through focus groups and interviews. And the enabling factors will assess the availability and accessibility of resources and services through resource inventory. This will help us identify existing HIV prevention and treatment services, as well as the barriers to accessing them. Barriers may also include the stigma that there is around HIV, transportation, and affordability. Phase 4, administrative and policy assessment and intervention alignment. Our goal is to reduce the rate of new HIV infections among the target population by increasing HIV testing and promoting HIV care. Our first objective is to increase HIV testing rates by 20% among our target population within our first year. And our second objective is to increase the percentage of individuals diagnosed with HIV who are linked to care within 1 month of diagnosis by 30%. To change these factors identified in the previous phases, we will use a combination of educational strategies, including community-based workshops, peer education programs, social media campaigns, and partnership with local healthcare providers. These strategies will be guided by the health belief model, which emphasizes the importance of perceived susceptibility, severity, benefits, and barriers, and motivating the behavior change. We will also work to develop policies that support our program success, like advocating for increased funding for HIV prevention and treatment services. Phase 5. Our program will be implemented by a team of trained healthcare professionals, community health workers, and peer educators that will collaborate. We will collaborate with local health departments, community organizations, and healthcare providers to deliver the program in various settings, including community centers, clinics, local schools, and online platforms. By implementing the program in these diverse settings, we aim to reach a wide range of individuals from the target population. Process evaluation. We will use qualitative and quantitative methods for process evaluation data collection. By tracking the program implementation activities, by monitoring attendance and participation rates and educational workshops and events, and conducting surveys and interviews with the program participants. by assessing participant satisfaction and perceived effectiveness of the program, and continuous collection of process evaluation data for timely feedback and improvement of the program. Phase 7, we will collect data on intermediate outcomes related to HIV prevention and testing behaviors. We will measure the frequency of HIV testing, knowledge of transmission and prevention, and condom use rates. We will administer surveys at specific time points throughout the program. And we will compare the impact evaluation data to the baseline data before the program. So we're going to compare the surveys in the beginning versus at point 1, which is a month after, and then a 3-month time period, and then a 6-month, and then a 1-year time period. And then we're going to determine the effectiveness of the program in bringing about desired changes in behavior and knowledge using these surveys. The outcome evaluation. Focus on assessing long-term effects of the program on reducing new HIV infections and improving health outcomes. Collecting data on key outcome indicators such as incidence rates, related mortality rates, and viral suppression rates. We will utilize ongoing surveillance systems and healthcare data sources for the outcome evaluation. And with the collaboration alongside local health departments and healthcare facilities for access to relevant data. Luckily, there are many federal programs that provide this data as reducing HIV rates as part of the Healthy People 2030 goal. Compare outcome indicators to baseline data and broader population trends. And finally, we will determine the program's contribution to reducing new HIV infections and improving health outcomes among the target population. And here's my works cited.